In this radiograph, this gas bubble here is indicative of a foot abscess. So again, those are very common in the front feet, and they can be very, very lame with those. Then obviously fractures. Cellulitis is a swelling of the limb, the soft tissue of the limb. It's usually all the way up. So from the foot to at least the carpus, if not all the way up to the elbow, or on the hind limb up to the tarsus, potentially even up to the sacral if it's a really intense cellulitis infection. If there's any septic synovial structure, so if they have an infected joint or tendon sheath or bursa, the infection builds pressure in that area, and that's what causes the pain. Solar puncture would be if they stepped on a nail. So obviously this is an image of a fracture, and then this is stepping on a nail. It can go through the back of their foot. This nail here, there's a lot of important structures back here. So the deep digital flexor tendon, the flexor tendon sheath, the navicular bursas in this area as well. So stepping on a nail back here is way more risky and has a worse prognosis than, say, if they stepped on a nail up here, where there's not as many synovial structures that could potentially be affected. They can have a lacerated tendon, or sometimes the problem could be higher up. So a nerve paralysis, so radial nerve paralysis, or calcaneal fracture, or something like that. So this horse has radial nerve paralysis. This was a case I saw during my internship when I was in Florida, and he, you can see he's got a face bandage on. He was actually under anesthesia for an ophthalmology procedure. I don't remember what they were doing with him, but when he recovered from anesthesia, he couldn't stand on his right front leg. You can see his foot's forward, his elbow's down, and he's just not putting any weight on it. So since it was a recovery from anesthesia, I don't believe he recovered poorly, but they can always fracture when they recover from anesthesia. So the top differentials for something that presents like this is an olecranon fracture, so fracture of the elbow, humeral fracture, or radial nerve paralysis. And since you can see this horse's right eye, he was laying on the right side, and the left eye was what was operated on. So we took x-rays, and he didn't have any bone problems, and so radial nerve paralysis was in the top differential. But you can see how this could look like a horse with a fractured leg as well, because he can't stand on it, he can't balance, it's really sore, but he had nerve paralysis. Some challenges we face with fracture repair in horses is soft tissue damage. In their lower limb, they don't have a lot between the skin and their bones, so there's less blood supply. Contamination, you can't always put a cast on right away, like this degloving injury here. The bone is exposed. There's a huge wound here that you're probably going to have to do wound management for, which makes it harder to put a cast on because you can't manage wounds under casts. It requires strong implants and constructs, so the implants and screws. Everything we have for fracture repair is what's made for people. So I believe we talked about last week, even the heaviest, most obese person probably at best is around 350 to 400 kilograms, which is a large pony. Some horses I've done fracture repairs on were 600 kilograms. Like some of them are very, very large, but we still only have the implants that are designed for people. There are really no horse-specific ones. Anesthetic recovery can present a challenge at times. Horses are prey species. Some of them get up well, some of them panic, especially if their leg is in a bandage or things like that. So you can have problems in recovery where you have a perfectly beautiful fracture repair and then recovery doesn't go well and the implants fail. And unfortunately, that just can happen sometimes. And then post-operative complications, the biggest one is laminitis, usually in the support limb. Horses were made to stand on all four legs, and if they have trouble standing on one, then there's more weight on the other three, and especially the contralateral limb, which takes more pressure and can result in laminitis. And so Barbaro in that first slide, he didn't die because of the fracture. He got euthanized because he got laminitis really bad in his other leg and couldn't stand anymore. There's also cast complications such as cast sores. They can have myopathies and just sores in other areas as well. And then there's also generally a prolonged hospitalization, which increases the cost, because that is something we always have to think about as veterinarians. At least here, I don't know how it is in your country, but we don't have There are some pet insurance companies, but it doesn't work the same way as with the human healthcare system. So everyone has to pay up front for their animals' care, and some people just don't have the financial resources to pay for it. So basic treatments for different types of fractures. So first off, you want to make sure you have some sedatives, because horses, if they can't stand on their leg, they're very anxious, they're very scared. And usually it's not because of the pain, it's because they're supposed to be able to walk on four legs, or at least stand on four legs. So once you can get the affected limb stabilized where they can stand on it even a little bit, they tend to calm down. So the main sedatives we have here are alpha-2 agonists, and we have xylazine, romifidine, and ditomidine. Those are three options. Xylazine is the shortest acting, romifidine is in between, and ditomidine is the longest lasting sedative. These are all good choices just to help get the horse calm so that they're not flailing about while you're trying to evaluate them and stabilize the fracture. Opioids for pain medication and also have a sedative effect. Butorphanol is a really good one that we have here. It can also kind of what we call plant their feet, so make them not want to pick up their feet, which is good when you want them to stay still while you're putting bandages on. Morphine is another opioid that we have, but it can have an excitatory response. So you want to be careful, because obviously we don't want to excite them. We're trying to keep them calm so we can stabilize their leg. Acepromazine is another type of sedative that we have, but it can cause hypertension or hypotension. And so with patients with blood loss, you may not want to give this because their body, they've already lost a lot of blood, so they have decreased volume already. You don't want to make that worse it causes vasodilation, which will lead to hypotension. And it's also not reversible. So the opioids and the alpha-2s are reversible, but ACE is not. So then those effects last up to 18 to 24 hours. Some analgesics, which the big ones we're going to use is NSAIDs. Here, phenylbutazone or bute is what we normally associate to treat bone pain, versus Banamine, or the drug name is flunixin meglumine, is what we tend to use to treat soft tissue pain. So in general, for fractures, they're going to be on bute versus the Banamine. And then potentially antibiotics as well, if there's a wound, contamination, things like that. However, if you're going to send the horse into a referral hospital, check with them first. They may not want you to put it on antibiotics if they're going to be taking it in for fracture repair anyway. So just try to communicate that just to see what the best options are for the referral center you may be sending the patient to. So the goals of fracture stabilization, the first one is to prevent damage of the neurovascular structure. So we want to try to keep everything as stable as possible so more damage doesn't occur. We want to keep the fracture bone from penetrating the skin and becoming an open fracture. Open fractures have a poorer prognosis no matter where they are compared to closed fractures, because there's higher risk of infection and contamination. And then we want to, if there is an open fracture, we want to try to protect the open fracture from becoming contaminated through the skin opening. So maybe it's just barely poking through. We don't want to make that worse. We don't want mud or manure or things like that to get into the skin where the bone is coming through. So stabilization can help with that. And then, as I said before, a lot of the anxiety and panic from the horses because they can't stand or use their leg like they're supposed to. So stabilizing the limb helps reduce that anxiety within the patient. And then again, just in general, minimizing further damage to the bone and soft tissue structures around the fractured area. So there's different types of fracture stabilization. One is called a Robert Jones bandage. There's also splints that can be used and casts. So a true Robert Jones bandage is many layers of cotton. You want the bandage to be about 3 times the diameter of the limb of the horse. So you can see in this picture, they put a ton of bandage material on this horse, and it's enough to be a lot wider than the average size of that horse's leg. If you're doing a bandage with a splint, it's what we call modified Robert Jones, or you just do 2 layers and then put a splint on. So you wouldn't need it to be quite this big, and I'll show you images of that shortly. Each layer of cotton is held in place with brown gauze, and you want to make sure each layer is tighter than the next one to get it as stable and secure as possible. Splints, what you look for in a splint is something that's economical and really easy and accessible in the field. You want something that neutralizes the forces of the fracture and also doesn't affect the ability of the horse to move. And so on this image is what we call a Kimsey leg saver splint, and I'll show you another picture of that in the next slide. So splint material, we want it to be clean and protective of any wounds. In general, depending on where the fracture is, you're going to place the splints at 90-degree angles to each other. So again, we'll place a bandage overlying the fractured limb, which is usually roll cotton or what we call a combine roll, which is also a type of cotton. And then brown gauze, vet wrap, elasticon. And again, we'll do 2 layers of that, which is called a modified Robert Jones. Splint materials. So this is PVC piping here. And that you can see this one where it has that brown. This was actually a heat gun was used on it to mold it to the limb. And that is a very common thing. You can get that at least here at a hardware store and cut it to fit the patient's size. And it's what we use most commonly for splints. The top and bottom, there's padding on it so the edges don't rub the patient. This is a Kimsey leg saver splint. They have ones that are made for the front leg and the hind leg. You can see this one coming down has a bent angle. So this is used on the hind limb. And you put a bandage on and then put their foot in here and then use these Velcro straps to strap it as tightly as possible around the bandaged limb. And then another thing, if you don't have splints, would be what we call bandage cast. So in this image, a bandage is being placed on the patient, and then this is cast material, which also happens to be purple, which matches the color of the vet wrap, is going around the limb. And so that is just a simple stabilization technique. It's stronger than just the PVC piping, but it's not, you need them to be, if you're going to put a straight cast on, they need to be generally place these under anesthesia where they can't move at all because there's not a lot of padding between the limb and the cast material, and it can create cast sores if they move at all. But with this one, because there's a bandage underneath, there's less risk of a cast sore, and this is a good way to temporarily stabilize the limb for transport. This is just pictures of how to put a bandage and splint on. This is one of my current patients in the hospital. She doesn't have a fracture, but she did tear a ligament on the outside of her fetlock on this leg. So this collateral ligament over here. So she's being managed in a bandage and a splint. She was in a cast and then a bandage cast, and now she's in a splint. And so this is how we, one of the ways to put bandages on. So this is the combine or the cotton roll all the way around the leg. This is the brown gauze being tightened. If we were going to do a modified Robert Jones at this stage, we would put a second layer of the cotton and the brown gauze before doing the vet wrap, and then elasticon at the top and bottom to 1, prevent the bandage from slipping, and 2, to prevent shavings or any debris from riding up underneath the bandage. And then this is her splint. And since she ruptured her lateral collateral ligament, the splint is going on the outside of her leg to help keep it stable. And so for this one, we're having to hold her limb up off the ground and then using white tape to secure it. And we just put it on initially and then let her put her leg on the ground and then put the tape the rest of the way on. And then we add duct tape in certain areas for extra support. The reason we aren't doing duct tape all the way up and down the limb is because duct tape isn't breathable. The white tape is. And so if we were to do it completely with just duct tape, they sweat underneath it. And so the bandage has to be changed basically every day. This way, because it's breathable, she doesn't get as sweaty. And so we're able to change it about every 2 to 3 days at this point, which just makes it easier on her and on us. So forelimbs, it's divided up into 5 areas essentially of where we will stabilize. So phalanges, metacarpus, radius, the olecranon, and then humerus scapula. So for the forelimb, the goal is to align the dorsal cortices of the phalangeal bones. So you want to essentially counteract the bending forces of the fetlock. And so to do that, the splint is applied on the dorsal surface. So again, this is that Kimsey Lifesaver splint. So you can see the bandage on the foot is in this metal part, and then the Velcro is wrapped around it. Or in this one, if you don't have it, you'll do a bandage. Again, that modified Robert Jones where you do 2 layers, and then you can do a board or PVC, and then attach that to the limb either with the white tape or the duct tape. And so you can see how the phalanges are in a straight line, essentially in that dorsal cortices. So that way, essentially the fetlock can't bend, so it can reduce the forces on the phalanges. For the metacarpus, you're also going to do a modified Robert Jones with that layered cotton or combine roll. And then you place a lateral and a palmar splint. So again, that rigid material, you can see the PVC plastic up here. And you want to go from the ground all the way up to the elbow on the palmar or caudal surface, and then from the ground up to the lateral aspect of the elbow. And we're trying to immobilize essentially the joint above and below the fracture. So you can see here if the fractures in the metacarpus, we want to stabilize the radius and the fetlock, and this is the easiest way to do it. So going just up to the elbow. This one was fixed in place with duct tape. If you're going to use duct tape and that's what you have, I don't know what similar thing you have in Thailand, if it is called duct tape there. But for here, we've got really cheap versions of duct tape and more expensive ones. And I always tell people buy the expensive one. So when you're trying to get this wrapped around, the cheap one tears really quickly and really easily. And when you're trying to quickly get a bandage on the limb and to get the limb stabilized when the horse has anxiety, you want something that stays in place really well. Also, when I start these, because the carpus is the most bendy part of the leg, I'll put the duct tape around the carpus and then at the proximal and distal ends of the bandage, and then kind of go in between just to try to get the carpus locked in place so they have a little bit more stability in their limb. For the radius, the purpose of the bandage is to prevent abduction of the limb because there's no muscular covering on the medial side. So when the radius is fractured, that almost always wants to displace the proximal portion medially because, again, there's no muscle here. And they're at a very high risk of becoming open fractures because there's nothing to prevent the bone from just popping through on the medial side. So for that, you do a Robert Jones and then a caudal splint from the heel to the elbow, and then a lateral splint that goes from the foot to the withers. And the reason it has to go up to the withers is to prevent that abduction. So you don't want the leg to be able to come out. And with the splint all the way up to the withers, it blocks the ability of the limb to abduct, which will help align the cortices of the fractures. You can see here how the limb is trying to pop medially. And by placing that very tall lateral splint, it gets the limb in a more straight alignment to help hopefully prevent that fracture from, if it's closed, from becoming open, or if it's open, becoming a more open fracture where the soft tissue structures get further damaged. For the olecranon, so the fractures of the olecranon disrupt the passive stay apparatus, the triceps insert on the olecranon. And so when that's a fracture there, the triceps can't engage and straighten the limb. And so it'll have a dropped elbow stance, very similar to what was shown previously in the horse with radial nerve paralysis. And so a Robert Jones or modified Robert Jones, and then a palmar splint from the heel to the elbow, because what we're trying to do is mimic what the triceps does, which is keep the leg straight. Because it's on the olecranon, we don't also need a lateral splint, just the caudal splint is enough. And the purpose is to keep the carpus in extension, and then they can weight bear on the limb in a more or less comfortable manner. For the humerus or scapula, there's really no splinting we can do. It's too high up in the limb. So essentially relying on the overlying musculature to help keep this fracture stable. A lot of times you can see in this image, okay, this horse also kind of has a dropped elbow look. It can't extend its carpus. So if you don't have radiology equipment or you're just trying to stabilize it quickly because the horse is panicking too much, sometimes you get it stable to the best of your abilities and then take x-rays depending on how your patient is doing. So in this case, we're not really sure. Dropped elbow, could be olecranon. could be humerus. So then you just want to splint it like a radial fracture just to be safe. You can't really over splint fractures, but you can under splint them, if that makes sense. For the hind limb, there's just 4 areas instead of 5. So the phalanges, metatarsus, the tibia and tarsus, and the stifle femur. And so again, we want to align the cortices, and for the hind legs, instead of aligning them on the dorsal surface, you're aligning them more on the plantar surface. That gives better cortical alignment. They have the reciprocal apparatus in the hind limb, which can kind of affect weight bearing. So this is the better way to do it. And so you do the bandage and then put the splint material from the foot all the way up to the hock. I usually just extend it all the way up to the top of the calcaneus just to have the best alignment possible. For the metatarsus, it's the same principle as the metacarpus, so trying to stabilize the joint above and below the fracture. And because of the angle of the hind limb, you're going to have a splint from the heel up to the calcaneus, and then a lateral splint from the ground up to the stifle. And again, it's that same principle to stabilize the joints above and below. And then for the tibia and tarsus, and again, tibia is like the radius where there's a lot of muscle covering laterally, but not medially. So they want to become open medially. So you want to try to realign the bony column and prevent fracture collapse or a closed fracture from becoming open and things like that. So for this one, the lateral splint is from the ground up to the tubercocci. On the front limb, it's the ground up to the withers, but you see how high this is going because the point is to prevent abduction of the limb. Stifle and femur, it's similar to the humerus and scapula. There's really no good option to immobilize it, so you rely on the heavy surrounding musculature, and there's really not much else you can do for that. Again, if you're concerned, you can still always splint it with a lateral splint that goes above the tubercocci just to try to help prevent abduction. If you feel like that's what's needed or you're worried, again, you can under splint, but you usually can't splint too much. So again, cast material, if you wanted to put a cast on like that bandage cast, it's a synthetic splint. We use fiberglass tape is what we have here. It's the most common casting material. And again, this is really hard to do in the field because a true cast, the horse has to be completely still. So we tend to place these under general anesthesia where they can't move, because it also takes about 10 to 15 minutes for the casting material to set. And if they move at all, it can create very small micro bends in the casting material, which can increase their risk for complications with cast sores. And so in the field, a bandage cast is a better option, again, where you place the bandage and then the casting material around that bandage. So a case to look at, this was, I believe, a 1-year-old horse that came in, and he had this dropped elbow appearance for, I think, at least a week at home. And so I'm just going to give you a second to think of some differentials and how you might want to stabilize this. I'm trying to remember his name. I think his name was Orion. This was a couple years ago now. So differentials for that dropped elbow appearance are going to be radial nerve paralysis, an olecranon fracture, or humeral fracture. So the stabilization for that is a modified Robert Jones and a caudal splint from the elbow to the ground. And if you're really worried, you could also do that lateral splint from the ground to the withers as well, but at least a caudal splint from the elbow to the ground, which is what we did for him. He ended up having radial nerve paralysis from an injury. And so you can't see the bandage under all the duct tape, but you can see just a portion of the splint there. And he, usually they have a pretty good prognosis with radial nerve paralysis, but his had been going on for quite some time before they brought him in. And the longer it goes without support, the worse prognosis it has. And unfortunately, he never regained full function of his radial nerve after about 2 or 3 weeks in the hospital. And so they ended up euthanizing him. But that doesn't normally happen with radial nerve paralysis. The example I gave you, the horse that had the radar paralysis from anesthesia. With the eye surgery, he was able to walk without a splint 2 or 3 days later. They usually respond pretty well. So again, this is just an image, the cotton and then the elasticon or vet wrap, and then elasticon top and bottom, and then that splint and then taping it around. Okay, any questions so far for just stabilization in general? Okay, doesn't look like it. So next up is how we classify fractures that we see. So there's different classification systems for adults versus neonates. So for adult fracture classification, it's either complete or incomplete, simple or comminuted, displaced or non-displaced, open or closed. It can be transverse, oblique, spiral, or just simply comminuted if it's in a lot of pieces. And then the location. So you want to name what bone is affected, what limb is affected, and then where within, if it's a long bone, the fracture is. So this image is just to go over the parts of the long bone. So growth plate or physis. Below that near the joint is the epiphysis, the metaphysis, and then the diaphysis is the center portion of the bone. So complete means that a fracture has an entry and an exit point, and these are usually transverse, oblique, or spiral. So in this image, you can see entry, exit point. The fracture goes all the way across. That is a complete fracture. It's from one cortices to the other. However, this is also a complete fracture. It's not going across one cortices to the other, but there's an entry and an exit point. And so this is a condylar fracture. These are fairly common in thoroughbred racehorses. So usually lateral condylar fractures are complete. Medial condylar fractures tend to spiral, which I have images of those later. So again, an entry and an exit point. So that makes it a complete fracture. An incomplete fracture has an entry point, but no exit point, or may look like a crack in the bone, if you will. So with this condylar fracture, you can see where the fracture starts, but it doesn't look like the fracture is exiting the bone in the proximal aspect of the condyle. Here's another example of an incomplete fracture. In P1, it's a sagittal fracture coming down the center. So you can see where the fracture starts, but it's kind of ending in the center of the bone. So there's no exit point. So this would be an incomplete fracture. So for configurations, again, that can be transverse, which is straight across. Oblique is at an angle. Or spiral, where it has multiple components. So there's a fracture line tracking this way, a fracture line going this way and that way. There's a couple small ones here. So this is a spiral fracture. And this is also an example of a spiral fracture, a little bit more severe. So you can see how the fracture lines are tracking up and over, and there's just the fractures in multiple planes. Simple versus comminuted. So a simple fracture is a single fracture line. So again, simple fracture. Comminuted has several fracture lines. So this one's got 1, 2, 3, 4, 5 that I can easily see in this view. She had even more on some of the other views. So simple, 1 fracture line, comminuted, several fracture lines. Displaced versus non-displaced. So non-displaced means the bony alignment is maintained. So the proximal and distal ends of the bone are basically still where they should anatomically be. So this would be a non-displaced fracture. Displaced fracture means the bone is pulled out of normal alignment. So as you can see, the distal portion of the radius is not in the same area as the proximal portion of the radius. When you describe these fractures, you actually describe the displacement based on where the distal portion of the bone is in relation to the proximal, not proximal in relation to distal. So for this fracture, just based on this view, I would describe this fracture as the radius being laterally and proximally displaced because that's what the distal portion is doing, if that makes sense. The only time that isn't true is in areas where there really is no proximal versus distal portion. So like the olecranon, it's an apophysis. It's not a long bone. It can't really displace any way but proximally as the tricep muscles pull up. So that would be one instance where it wouldn't be described like this, but 99% of the time it's the distal bone in relation to the proximal portion of the bone. So open versus closed. Closed, there's no skin defect or no gas opacity near the fracture line. So there's no gas around this area. This is the bandage that was on when they were taking this radiograph, but there's no gas opacities or anything like that. Versus open, there's a skin defect in the area of the fracture, or sometimes just a gas opacity near the fracture line on the radiograph. So it's not always an obvious wound. But here in this fracture, you can see a lot of gas opacity around the fracture. So this is definitely going to be an open fracture. And here's another one where you can see the gas opacity and how the bone, this is the radius trying to displace medially. Neonatal fracture classification is a little bit different. They can be described as an adult, but they also have a special classification in relation to where fractures are near the physis. So type 1 is the physis itself. So it's a separation. So you can see a little bit better in this image where the type 1, the physis is coming apart. Type 2, it's from the physis to the metaphysis. Type 3 is the physis to the epiphysis. Type 4 is all of it, so the epiphysis, physis, and metaphysis. And type 5 is compression. So you can see in this image a little bit better where the physis is compressed on itself. These little letters here that spell Salter, another way to remember it is type 1 is sliding, again, where the physis is either sliding or separating. 2, with it being the physis to the metaphysis, you can say that's above. That's where the A comes from. Type 3, since it's the physis and epiphysis, it's below the physis is where the fracture is going. So that's where the L is. Type 4, again, from the epiphysis, physis, metaphysis, or through all of it, it's where the T is. And then R, because it's type 5, is either crushed or you can say it's ruined. And that's where the R comes from. So it's a little acronym that also sort of spells Salter, is a different way to remember it. Some people find it helpful, some people don't find it helpful at all, but it's there just in case it would be helpful to you. So looking at this fracture, I'm just going to give you a second to look at it and kind of think about how you would describe this fracture, and then I'll go over the answer with you. So this fracture is not in a horse, it is in a goat, I believe. So you can see it's got claws, so it's got its medial and lateral claw, and so the metacarpus, or metatarsus in this case, is fused. So it's the fused third and fourth metacarpus instead of just saying third like it would be in a horse. So this fracture, it's complete, it's simple, it is displaced. And again, we describe the displacement from the distal portion in relation to the proximal portion. So it's displaced laterally, dorsally, and then proximally, which you can see on both as it's moving up. It appears closed. However, there are a couple little gas bubbles here, so you could potentially say it might be open. This is one where you'll know more by looking at it. Is there a wound there? Configuration, it's a transverse fracture. And again, it's located in the distal metaphysis of the left fused third and fourth metatarsal bones. You don't have to say left hind because you have metatarsal, which automatically means hind. And again, because this is a ruminant species, it's the fused third and fourth. So if we wanted to do the full description, it's a complete, simple, closed, lateral, dorsal, and proximally displaced transverse fracture of the distal metaphysis of the left fused third and fourth metatarsal bones. So that's the full on description of this fracture if you're going to try to describe it to somebody. Prognosis for fractures, there's many variables that come into play. So some is the type and location of the fracture, the purpose of the horse. Some fractures, they can go back to being athletes. The condylar fractures that thoroughbred racehorses get, the simple ones that they have in the lateral condyle where they're just simple complete and they're not spiral. Those get fixed, they go back to racing, they do fine. Even some with spiral fractures can go back to racing, but some fractures, they're not going to have an option of being an athletic horse. And so some owners may not go for fixing it if they want an athlete, and they won't have an athlete once the fracture is repaired. Signalment can also play a part because of size. A pony is going to have a better prognosis than a draft horse because a pony weighs closer to the weight of a very large human versus a draft horse that weighs, over 700 kilograms. If you're not sure about the prognosis, the best thing to do is call a referral center and speak to a surgeon there if you need to give more information to your client so they can kind of figure out what they want to do. Poor prognosis are associated with complete fractures, especially when they're unstable. Again, if they're open fractures and highly contaminated, so like this horse, if he has a fracture, it's covered in mud. If it's open, that's just going to be a much poorer prognosis because the risk of infection of the implants is a lot higher when it's open and contaminated. Articular fractures have a poorer prognosis because you have to make sure you can get proper joint congruity when you fix the fracture, and then there's damages to the articular surface, which can decrease prognosis. The degree of soft tissue and vascular damage, as I said earlier, there's not as much blood supply in the lower limb compared to the upper limb. So without blood supply, oxygen and healing factors have a harder time getting to the area to help promote healing. And then long bone fractures that are proximal to the canid bone, so proximal to the metatarsus or metacarpus. There's decreased ability for internal fixation and external coaptation higher up the limb. And again, because there's muscle on the lateral side, but not the medial side, those fractures are more likely to be open and contaminated, which decreases the prognosis. They also need stronger implants higher up because the bones are bigger. And again, we only have implants that are made for people, so it can make fracture repair a little complicated. Better prognosis, if incomplete fractures of long bones, you can put them on stall rest. And this image, you can see there's a line going across here, and the horse is actually tied to the line. This is to help prevent the horse from laying down. You could also put them in a sling if they're in a hospital setting to help prevent this. With that said, I have had horses that we've tied for various reasons. And if they want to lay down, they will figure out how to lay down. And I've had some lay down and just have their head extended up against a wall for support so they could lay down. But the reason you're trying to prevent them from laying down is getting up and down could make an incomplete fracture complete and then decrease the prognosis. So if we can keep them standing and not putting the extra stress of getting up and down, it can have a better prognosis. If it's an incomplete fracture that goes into a joint, it has to have internal fixation because we have to maintain joint congruity. If we don't, then they're going to get severe osteoarthritis in their joint over time and then have pain from that. So if the incomplete fracture does communicate with the joint, it does have to have internal fixation. It can't be managed with just stall rest alone. Prognosis, again, complete fractures of the phalanges and long bones, they're usually displaced, so they have a poorer prognosis. They can be very difficult to reduce, especially higher up in the limb, because muscles are counteracting the forces of you pulling on the leg to try to reduce the fracture. You can prepare them with internal, external fixation. So external would be like external coaptation, like a cast. Foals in general have a better prognosis because they're lighter weight. They also lay down more, so they're not standing on their fractured limb as much as an adult would. And again, other considerations, recovery time, cost, the nature of the patient. So this patient who's rearing and just having a hard time, if they're very interactive and very active and don't handle stall rest well, they're not going to have as good of a prognosis because they could break the implants or have other issues that reduce the overall prognosis. And again, size and weight of the patient. So this pony is going to have a much better prognosis than this giant draft horse because just the weight of the two. And then again, intended career for the patient. So some fractures, they can go back into having a full athletic career after they're healed, and some they are pasture sound or sound for breeding, but nothing else. And that can determine whether a client wants to move forward or not. So some special considerations just in general. Sometimes the horses are recumbent. They could get stuck in a ravine. They could be stuck in a ditch. There's many reasons why the horse might be down and unable to get up. And so we have, I've done the training a couple of times here where there's actually like equine rescue training where we get the fire department and other groups and train them on how to handle horses, because they might get called out to help with that, even though they aren't veterinarians, but under the supervision of a veterinarian to help move horses. So if the horse is down and you have to move it, you're going to have to sedate it, most likely put it under general anesthesia in the field, which here we have ketamine as our main medication that we use for in the field anesthesia, because most horses aren't going to let you pull them around while they're awake. You want to stabilize the limb as you would if the horse was standing before you move them. That way you're protecting the fracture as much as possible. So you can see this horse is actually in a huge Kimsey leg saver splint with the bandage and the splint on as best they could and strapped down to try to protect the limb. Transporting them via sliding the horse on a tarp, or if you have these are, we call them skids here. If you can get the horse on the skid and then slide them, you can see a better picture here. It's got holes in it that you can put lead ropes on, and you need to have a team of people to move the horse. And then you just move them into the trailer on the tarp or on the skid. For transportation of the horse with a fracture, whether this would be for when it's standing, you want to think about brakes and momentum. And so that matters with how you want to put them in the trailer. So for forelimb fractures, you want the horse to face backwards and have the hind end towards the front, because when you brake, when you're driving, all the force goes forward before it comes back. So that way the hind legs, which aren't fractured, can take the brunt of that decreased momentum that throws the weight forward. So it's taking some of the horse's weight off the front leg. If it's a hind limb fracture, then you would reverse that and face the horse forwards for those same reasons to reduce the force on the fractured limb. There are also specialized emergency trailers that we have. When I worked in California, we were close to a lot of racetracks. So there were emergency transport trailers that had slings in them, these padded areas to help keep the horse up, help pad them from the sides, and just overall support them while they're being trailered. You can see this horse is was put in as facing backwards because it's a front limb, and this horse is facing forwards with its hind limb fracture. So interview, when get a good history from the client, figure out what's going on so you can plan ahead, bring the supplies that you need, triage the patient, stabilize, and refer if needed. This image here is one of those training groups I was talking about where they have, we call a model horse, and go over how to safely pull them on the ground and pull them into a trailer. So you can see the ropes attached to the little holes in the skid, and these people trying to help pull the horse into the trailer. So then I've got a couple cases for you just to kind of look at, we can go over. So case one, the owner calls, found their horse outside and it was non-weight bearing on the left hind limb. These are the radiographs taken. So you want to think about how you would describe the fracture and how you would stabilize the limb. So we'll go to this slide and just let you look at it for a minute, and then I'll go over the answer. So location is the first phalanx of the left hind limb. It's a complete fracture because it's going through, there's an entry and an exit point. As far as we can tell, it looks closed. There's no obvious gasopasties. You can see the edges of the skin, and it doesn't look like any of the bone is puncturing through the skin. It is displaced, and it's displaced plantarly and proximally, because again, it's the distal portion of the bone in relation to the proximal portion of the bone. So distally, it's going plantarly and proximally. This is a comminuted fracture. There's multiple fracture lines. and it might be articular. We can see that this fracture line is at least going up to the physis. Is it tracking up higher? We don't know. This would be something that, say, I got these 2 radiographs sent to me from someone in the field. I would tell them I can't tell if it's articular at this point, but send it in, and we would take more x-rays once the patient got here, especially if we were going to take it to surgery for surgical planning and things like that. So the final description of this fracture is a closed, complete, comminuted fracture of the first phalanx of the left hind limb with plantaro-proximal displacement and possible articular involvement of the metatarsophalangeal joint, which again, this is something more, I give these examples just so you can see the full on description, but this is something like I would have to do for my surgery boards, but it's not expected of a ambulatory practitioner to say all of this, but just so you know things that we might ask for if you were to call about a fracture. The next part is how to stabilize it, which would be a modified Robert Jones. You want to align the cortices either with the plantar splint or the hind limb Kimsey leg saver, which isn't going plantarly, but it's bent down here to get the cortices aligned appropriately. And the splint, if you're doing a plantar one, should go from the toe to the top of the calcaneus, or again, this is that Kimsey leg saver, so it's going as high as the tarsus here. Second case was a patient that's non-weight bearing in the left hind limb. So again, just to describe the fracture and how would you stabilize it. So just so you can look at it again. The location is the left tibia. It's a complete fracture. It appears closed. Again, no obvious gas opacities that look like it's breaking the skin. It is displaced, and it's displaced proximally, cranially, and then on this image we can see laterally, because again, it's the distal portion in relation to the proximal portion. It's a comminuted spiral fracture, so you can see how it's spiraling up the limb. There's multiple lines going up, and you can see even here it is a nice kind of curve around like a spiral would. It does not appear to be articular. And so the final description would be a closed, complete, non-articular, comminuted spiral fracture of the left tibia with proximal, cranial, and lateral displacement. The appropriate way to stabilize that would have been a modified Robert Jones and a lateral splint from the ground all the way to the tuber coxae to prevent abduction of the limb and try to protect the medial aspect of the leg. And so this was actually a calf that came to me a couple of years ago, and they referred it in with a bandage on. They didn't ask how to stabilize it. So it came in, it had a poor prognosis to begin with anyway, but the owners wanted to try and do a Thomas Schroeder splint like we talked about last week. And so when the patient got here, you can see in the radiographs, this is the bandage that was placed. It did not have a splint on. There was no other stabilization other than this bandage. And the fracture became worse because it wasn't stabilized appropriately. The other reason this is unfortunate, just putting the bandage on from essentially the stifle all the way to the ground without a splint basically just made the leg heavier, and it acted as a pendulum, which propagated fracture lines. So just so you can see, these are the radiographs that they're referring sent. And you can see there's more cranial displacement. There's another line here, but most of the damage you can see on the cranial caudal view. So again, this is the radiograph that I was sent, and this is the fracture the next day. There's more lateral displacement and more proximal displacement of the distal portion. There's more fracture lines. And there's a fracture line propagating down. So at this point, we had given them probably a 10% chance of being able to have some sort of function with the prolonged Thomas Schroeder splint on. However, at this point, because of the propagation of the fracture and the increased instability, we said the Thomas Schroeder is not going to do anything, and so they opted to euthanize. But this is just a good example of why proper stabilization is so important, because this was about within, I think I got the call in the afternoon about this, and the calf came in that next morning. So 12 to 15 hours later, huge change in the fracture and prognosis for the patient. Case 3, this horse presented for a possible fetlock fracture, and this is how the limb was stabilized. So think about, is this a good stabilization technique? And then how you would potentially stabilize the limb if it was a possible fetlock fracture. So this is not appropriate stabilization. These are little pieces of wood that we have here to mix paint and paint cans. So they're very thin, probably maybe 2 to 3 millimeters thick, not very strong at all. So not a good way to stabilize this. The best way to stabilize it would be a modified Robert Jones, and to again align the cortices up to the calcaneus if you can, and the splint should be from the toe all the way to the calcaneus. Versus again here, it was at the mid-metatarsal level. It wasn't even all the way up to the hock, because if it is a fetlock fracture, we need to stabilize the joints above and below, which would be preventing movement of the tarsus, as well as the proximal and distal interphalangeal joints, which it definitely did not get at all with this stabilization technique. So, any questions so far with how to classify fractures, how to stabilize them, or anything like that?
Anybody has any question? If you don't want to talk, you can put your question on the chat. Do you have any question? Seem not, Jordan?
Nothing? Okay. This is Mariska. She was the case 1 with the comminuted P1 fracture. This was her. She was a foal that I treated during my residency. She was in the hospital for 10 months while we did all of her therapy. We'll have more pictures of her later. Okay, so then the next part of the lecture is like, how do fractures occur? So going over bone and fracture biomechanics. This gets a little intense. So you have the slides ahead of time, so hopefully you're able to read over them. But we'll kind of get into why bones fracture and how that happens. So bone stress, there's what we call intrinsic forces, which are forces just within the bone and the surrounding tissue. They're limited in force and magnitude because it's what's in the body. And most of these forces are from the tendons, ligaments, and joint surfaces. So they just are what they are. They can be static or dynamic because as you move, the forces change. When I'm standing on my right leg, there's more force on it than on my left leg because I'm not standing on it, and vice versa. So that's the static dynamic component. And then extrinsic forces are anything that originate outside the body. So there's no limit to orientation or magnitude, meaning I could be walking and then get hit by someone on a bike. And those forces from the person hitting me on the bike could be all over the place on my body. I can't control those because it's an outside force. Important properties of bone that we'll talk about are strength and stiffness, because all those play a role in fracture development. And then load, which is the externally applied force, which causes deformation in the bone and a change in dimension. And we load our bones constantly. Every time you move, you're loading your bone in some way. When you walk, there's load that's placed. When you run, there's load that's placed. And that load and those forces will change the shape of the bone because of Wolff's law, right? More bone will be laid down where it's needed and where it's used. So if you are a runner, you're going to have more bone deposited in some areas in your legs than someone who doesn't run, just because of what you're doing with your body and your body's trying to support itself. So race horses are going to have more bone deposited usually on the dorsal surfaces of the metacarpal and metatarsal bones. Compared to horses that are just hanging out in the pasture or doing something different. They may not have the same amount of change in their bone. So the load deformation curve is what we use to determine like when something will break. So the elastic region If the bone is only loaded in this region, it will return to its original shape when the load is removed. So this is you walking, your legs are used to walking. So, okay, there's more force when you're standing on your leg than when you're not, but it's used to this. So it will deform a little bit and then go back to its original shape. And these deformations are microscopic, obviously. The yield point is when the bone will no longer return to its original shape once the load is removed. Now, this could be a negative connotation as, oh, it's about to fracture, or as your bone is changing when you're exercising, it will get to a point where, okay, the load is too much. Now the bone needs to change shape to be able to handle the increased load over time. So some of this isn't negative, it's just how the body reacts and how the bone changes as you're exercising and things like that. The plastic region up here, the bone deforms at a much greater extent for the given load compared to the elastic region, meaning the bone is less stiff. And then the ultimate failure point is when the bone fractures. So there's a lot of time before it actually gets to the fracture point. But if this happens really fast, so again, I'm walking, get hit by a bike, all of that's going to happen quite quickly versus a racehorse where they're running, and then all of a sudden it gets to the point where the changes in their metacarpus aren't enough and they get like the condylar fracture that I showed you earlier. 3 parameters for the strength of bone is the load that the bone can withstand before failing, the deformation it can withstand before failing, and then the energy that it stores before failing. And energy is really important. And energy is this area under the curve, which another term for it, depending on if you're reading something, can also be called toughness. And that's basically the ability of a material to sustain deformation without failing. And so again, there's some movement in the bone that changes as you're exercising and doing things. So it should have some deformation to be able to adjust to new loads, a new exercise and things like that without fracturing. But it can get to the point where too much is done and then it does actually fracture. Elastic energy is the energy that's stored before the yield point, so before it fractures. And then the plastic energy is the area under the curve from the yield point to ultimate failure. So elastic energy and then plastic energy. So if the bone has greater toughness, it has greater energy, but then there's a rapid release of the stored energy. So that means there's actually greater comminution and greater soft tissue damage, the fracture, versus if it has less toughness because it's able to deform a little bit easier, and then it doesn't store all of think of it as like a spring loaded. The more pressure you put on the spring, it can hold a lot, and then all of a sudden it can't hold anymore, and then it's just going to explode out. And that is bone with greater toughness. It has a rapid release of stored energy. So when racehorses are running and their bone breaks, that's why they're usually pretty catastrophic, because there's high energy, there's high load because they're galloping on it. There's a lot of stored energy in usually their metacarpal bone, and then the fracture occurs. So if there's low loading, there's less energy stored because you're not putting a lot of pressure on the bone. So it tends to be more of a simple fracture, versus high loading. There's more energy stored, more energy that's being used, more complex or comminuted fractures. So again, that racehorse that's galloping, there's a lot more energy within their body, within their bones to be able to run that fast and do what they're doing. So the ultimate strength is based on the ultimate failure point. And then what we call stiffness, which again, I know this is a lot of kind of like physics and things, is the stiffness is the slope of the elastic region of the curve. So again, elastic region, stiffness, the steeper the slope, the stiffer the bone, which means it doesn't have a lot of capacity for deformation. So it's not as changeable as some of the other bones. And then if it's stiffer, it's going to fracture easier because it doesn't have the ability to adjust as well as some of the other areas of bone. So another type of curve that we talk about is the stress strain curve. And so stress is just the force per unit area on the surface of the bone, and it forms in response to an externally applied load. which sounds really complicated, but again, if you're walking, when you stand on your right leg, the external force is what the ground is pushing up into your leg. And so that is stress and load applied to the bones of your right leg as you are walking. And so normal stress is the intensity of the internal forces perpendicular to the plane that passes through the bone, which is basically walking on the ground, and then your tendons and ligaments trying to keep you stable as you're walking around. In general, they consider tensile stress to be positive and compressive stress to be negative. And then shear stress goes in multiple planes around the limb. And we'll talk about that as far as these forces and how they create certain types of fractures. So strain is a localized change in dimension that develops within a structure. So again, you went from not being a runner to starting to run, and you're putting strain on your tendons and ligaments and your bone as you're going from being a walker to a runner. So again, strain's not bad. It's just what is stimulating changes within the bone structure. Linear strain causes changes in the length of bone, and then shear strain causes changes in the angular relationship within the bone. And so again, we'll talk about shear forces shortly. And so this is the stress strain curve. It looks very similar to the other curve, and it has an elastic and plastic region. And again, this is all just kind of basically where the bone is going to fail and then eventually fracture based on the stresses that are applied to it. And again, the yield point is where on both curves, at the yield point, it can't return back to the original shape once the load is removed, which it doesn't necessarily mean something bad. As your body is changing, as you're exercising, lifting weights, the horses are running, things like that, the bone should be changing to accommodate those changes in force. So it's not necessarily a bad thing, but when it gets to that ultimate stress and failure point, that is when the fracture occurs. And obviously, fractures are not ideal. Some of the properties of bone will determine how much energy is stored and things like that, and kind of help predict what type of fractures may occur in those areas. So cortical bone is the hard bone. It's on the long bones. It's what's kind of lining the metaphysis and diaphysis. It is a lot stiffer than cancellous bone. So because it has more stiffness, it fails at lower strains because since it's stiff, it can't change as much. So it has a very limited capacity to change its shape. And so it can fail at strains as low as 2%. It's also more brittle because of that stiffness. It, again, doesn't change, doesn't handle forces as well, so it has more tendency to fracture. Versus cancellous bone, which is also known as woven bone or lamellar bone. It has, I don't know why it has 3 different names, but it does, and they're all basically the same thing. You can see it's much more porous, so it stores more energy, so you can have more catastrophic fractures in these areas. But they fail at a higher strain because since they're porous and less stiff, they have the ability to change easier than the cortical bone. So they can handle higher forces before they fracture, but because they store more energy, those fractures can be more catastrophic. Bone strength in general, bone is strongest in compression and weakest in tension, and that'll come into play when we talk about repairing the fracture. Shear forces, it's stronger than tension but weaker than compression, so it's kind of in between as far as forces are applied where the bone strength is. So tension is basically equal and opposite traction on both ends of the bone. So basically just trying to pull, that's all that the tension is. So the structure lengthens and narrows. For the bone specifically, failure occurs because the cement lines around the osteons, they get pulled so much that they aren't bound anymore. And so the osteons just pull apart. So they're just like popping something off. The maximal tensile stress is a plane perpendicular to the applied load. So when they fracture because of tension stress, they tend to have a transverse fracture. It just goes straight across because, again, you're just pulling and popping it apart. Common locations for fractures and tension are the proximal ulna, the proximal sesamoid bones, because that's where the suspensory ligaments attach. And so we'll see what we call apical sesamoid fractures, where the suspensory ligaments just pops off the top of the sesamoid bones. It can happen in the patella. Those tensile forces are usually the patellar ligaments, and then the calcaneus as well. Compression is the opposite. So it's equal and opposite compressive loads applied at the end of the bone. So it's forcing the bone down on each other, and it shortens and widens. And so the microscopic way that this fails is through the osteons, and it usually fails at about a 45-degree angle. And it occurs at a plane perpendicular to the applied load, but because it's at a bit of an angle, this is how we tend to get oblique fractures, because it's pushing, and then it eventually just shifts like this as the compressive forces get too strong. Pure compressive fractures are rare in horses. But again, if they do occur, they're usually short oblique fractures. And a lot of times, which we'll talk about in a minute, they start off transverse because they're failing in tension, and then they get to the compressive side of the bone and then make a butterfly fragment, which I have an image of that a few slides down. So shear loads are applied parallel to the surface of the bone, and it deforms in an angular manner. So an example of this are the sliding physeal fractures when they kind of separate and slide. Like a true shear fracture is also very rare. They tend to fail, especially say a racehorse or something, in multiple planes because there's a lot of forces working at once. Bending occurs when loads are applied that cause the bone to bend around its axis. And this is more what we see. It's usually a combination of tension and compressive forces. So you can see here, there's the tension that's pulling this bone up. So on one side, we'll say that this is the lateral side and this is the medial side. The lateral side is under tension because it's being bent, and so it's pulling apart laterally. But then on the medial side, it's being forced together because that's how bending works. And so this is what we see more commonly where we get these butterfly fragments, because on the tension side, it's going to create that transverse fracture. But when the compressive forces outdo the tension forces, then it breaks, then it fractures obliquely, and it tends to do that in two planes, which gives us this butterfly fragment. So it starts off transverse and then becomes oblique because, again, the compression just comes together and eventually just does this. And as I said, the bone will initially fail in tension, and then as it gets to the compression side, that's where other forces come into play, and we get a partially transverse, and then it becomes oblique fracture lines to get that butterfly fragment. Torsion, the bone is twisting around its axis. This gives us usually the spiral fractures, as you can see in this image, where there's just a bunch of different forces on the bone because it's just being twisted. So parts are being pulled, parts are being compressed, there's shear forces. And so there's fracture lines all over the place. So these cause a lot of the spiral fractures. The shear stress is greatest at points parallel and perpendicular to the neutral axis. So again, this is what will cause these fractures to propagate up in multiple planes, because as the bone is twisting and torsion, there's a lot of different forces that are coming into play, and this is those oblique spiral fractures. Combined loading is the most common loading pattern for daily activity. So as I've been talking about, the forces on the bone are altered just by living. You go for a walk and you step on a rock, and then all of a sudden, instead of being flat-footed, you're slightly tilted. So part of your body's in tension and part of your body's in compression as you try to rebalance. And all of these things will change the shape of bone, especially if it's repetitive. So again, being a walker versus a runner, your bone density is going to be different because you need the bone to support different amounts of load. There's more load when you're running versus when you're walking. Geometry of the bone also influences the behavior. So tension and compression, the load to failure and stiffness are proportional to the cross-sectional area. So the larger the area, so the larger the bone, the stronger and stiffer it is. So like your femur is going to be stronger and stiffer than your ulna because it is a bigger bone. It has a larger area. So it's also going to take more force theoretically to fracture your femur versus your ulna. And then again, with bending, the cross-sectional area distribution of the bone tissue is around the neutral axis, and that's what affects the behavior of the bone. And this is more based on the length of bone, because the longer the bone is, the more you can bend it around before it snaps. So again, the longer the bone, the greater the magnitude of the bending forces. And the easiest way to think about this is if you have a short stick and a long stick, the longer stick you can bend a lot more before it snaps, but it's going to snap with a lot more force than the smaller stick that you can't bend quite as much because it's just not as long, so it doesn't have as much mobility with those forces. Hopefully that all makes sense. When I give this lecture in person, I bring things with me to kind of demonstrate these things. Hopefully my hands are enough. For horses, long bones, because they're the longer bones, are subject to the highest bending moments. They can tolerate a lot of tensile and compressive forces, but again, when they fracture, it can be a lot more catastrophic because they can handle a lot more force, store a lot more energy, and then when they fracture, that energy is released into the bone and surrounding tissue. Just a comment on something that we call stress risers. These are geometric irregularities and sudden changes in the material properties within the bone, and they produce a high localized stress to the bone under loading. And from a surgery standpoint, the most common causes of this are going to be sharp corners on the edges of our plate, holes in the plate when we are repairing fractures, if there's notches in the bone, or if you don't get good anatomic alignment and there's irregularities, that can cause extra stress there. And in general, if there are stress risers, it's weakest under torsional loading with the twisting. These are just schematics to go over the different types of loads and how these fractures can occur. Any questions after that very long and drawn out discussion on how bones fracture? I know that's a lot of information in one go. Okay. Then I'm going to talk about fracture repair. I don't know how much you all have been taught in class, so I'm going to go over give an example of a fracture that I've repaired and kind of go over the steps and some other things. So like I said, ask questions in the chat if you have any, and we'll just keep on trucking. So principles of long bone fracture repair. Again, there's forces that cause characteristic fracture configurations. So certain bones are subject to characteristic forces. So the cannon bone, which is what we call the third metacarpal or metatarsal bone, is loaded almost completely in compression. So they tend to get those butterfly fragments when they fracture. There's less options to repair long bone fractures in adults, as we've talked about, the weight of the patient, things like that. Because they're bigger, their bones store more energy, so there's more likely to have comminution, especially higher up in the limb. For adult horses, there is no option for femur fracture repair. There is no option for humeral fracture repair. And for most of them, there's very limited to any options for the tibia or radius either, because again, for adult full-size horses, the plates that we need, we don't have because they aren't made. So we're just using what we have for people. And most of them are not strong enough to be in place long enough for the fracture to heal, because our patients have to not only walk on their limb after, they have to stand up. They have to recover from anesthesia and stand up on their leg, which if you break your femur, you're not going to be walking on it for a while. You're going to wake up in a bed, and it's just a completely different type of things we have to think about in these large patients when we repair their fractures. So again, kind of repeat slide, but proper case selection, patient size, patient temperament, all of those things. So proper equipment, and I try to do a brief overview of the equipment. I don't know what you all have learned in class, and so I'm just going to go over some of the basic things we use in horses. In general, for a full-size horse, the widest plates that are in production are what we call 4 or 5 plates. They can be broad or narrow, and then I just have the acronyms for the type of plates, and I'll have pictures of them in another slide or two, and I'll go over a little bit more there. The main screw sizes that we use are 4/5s and 5/5 Cortex screws. I will say the 5/5 Cortex screw, which was 5.5 millimeters diameter, was developed specifically for horses. I'm sure they use it in people as well, but it was developed for horses. And then 4/0 and 5/0 locking screws. And these are the biggest size screws that we have for most things. So 4.5 millimeters and 5.5 millimeters isn't really that big, but that's what we have. You also want to make sure you have an experienced team of surgeons. I have images of this later on. We did fix a radial fracture in a pony last year. And so I was scrubbed in along with another surgeon so we could get things going and move and try to get them off the table as soon as possible. The longer they're under anesthesia, the higher risk they could have complications post-op. So trying to get people in to get it done quickly. And then you need to make sure you have an adequate recovery room and or pool system. Most places don't have a pool system, but I do have pictures of that in this lecture. University of Pennsylvania has a pool system. Some private practices do, but most places just need to have a good padded recovery stall, head and tail ropes to help support the horse, and then people who are trained on the ropes. And the head and tail ropes, you are not strong enough to lift a horse out by its head or its tail. That's not the purpose. The purpose for them is just to help support the horse as they try to stand up. So you can try to guide their head in a certain direction. And if they're a little wobbly, you can kind of use the tail rope to help balance them a little, but you can't lift them with those things. I've seen people try and it doesn't work. They are just too big. So these are some of the plates that we have, and they have these on small animal as well. So this is a DCP, which is called a dynamic compression plate. And this was one of the first plates developed, probably 50 years ago, but it's flat all the way around. The next invention was what they called a limited contact dynamic compression plate. And so you can see here, there's little cutouts in the plate, so the bottom isn't smooth. And this was developed actually for people because when they were using just a DCP plate, people produced a lot of excess bone that was growing over the plate, which made them hard to remove and had issues with the bone plate contact. But for our animals, the large animals, we actually want that contact because that makes the plate and bone kind of a singular unit to make it as strong as possible. The other thing just to point out, you see how all of these holes are in a straight line. This is a narrow plate versus this plate where the holes are kind of offset from each other. This is a broad plate. And it would look the same if this DCP was broad. It would also have holes that were offset. And then the newest one that we have, and this is probably within the last 10 to 15 years, is a locking compression plate. And so with this one, there's 2 different types of holes. A Cortex screw can go here, or what we call a locking head screw, which is what this is. You can see it has what we call threads all the way up to the head of the screw. So the screw actually completely screws into the plate. And so it makes it a lot stronger of a construct than when we use Cortex screws, which just sit on the plates. The Cortex screws will push the plate onto the bone, and the locking head screws do that, but since they screw into the plate as well, it's an extra amount of support because the screw and the plate basically become one unit instead of 2 separate. And so you can see in this image, the locking head screw is basically seated into the plate versus a Cortex screw is a little bit above the plate. And this one, because the holes are not in a straight line, this is also a broad plate. But just to go over kind of some of the differences, like I said, these are used in human medicine. They have them in small animal. There's also other specialty type of plates that I'm not going to go over, but these are the basics that we use for fracture repair in horses are these 3 plates and these 2 types of screws. Some fractures can be managed non-surgically, as I said before, so incomplete fractures with stall rest. So like this horse, you can see the fracture line here with these arrows, so it's an incomplete fracture. Again, prevent them from lying down. And this can work for the humerus, radius, femur, and tibia. So again, these fractures that we don't have plates strong enough to repair them in adult horses. Some of them, depending on where it is, you might also do stall rest with some form of external coaptation, so a cast or a bandage cast. But if the fracture is proximal to the carpus or tarsus, you don't actually want to cast them because it changes the force on the bone and it actually just makes the leg a heavy pendulum and can make the fracture worse. This is just a case report of an incomplete fracture that was managed. It was a radial fracture, complete and non-displaced fracture that they were able to stabilize and heal with stall rest over time. So you can see the bone callus formation, and the bone did slowly heal over time. And so this was one that was actually able to be managed with stall confinement and time, and the horse did okay. But this was only possible because the fracture wasn't displaced. If there was any displacement, you couldn't do this for a radial fracture. Surgical management. So you want to have good preoperative planning. So you want to make sure you know where the fracture is, what plates you're going to need, what screws you're going to need, manage client expectation. This is an olecranon fracture I repaired a few years ago, and we'll see this horse again later on in the lecture. And the biggest thing with managing client expectations is, as I said before, you could have the most perfect, beautiful reduction and repair, and the horse has a bad recovery and breaks the implants, and there's nothing you can do about it. We support them as best we can in recovery, but we never know what they're going to do. And that's the biggest thing I think with managing client expectations, is that even though this is a pretty common fracture to fix or what have you, we don't know what the horse will do in recovery. And that is really the scariest part of all of this. This was the first big fracture repair I did by myself, and the surgery was fine, but I was very sick and nervous during recovery because I didn't know what this horse was going to do. And this horse was 600 kilograms. He was a big boy. So the biggest thing again is planning, making sure you know what you need. For this horse, with the radiology equipment, you can measure the thickness of the bone. So I had an idea of what length screws I was going to need for higher up in the olecranon versus down here in the ulna. So all of those things for kind of pre-surgical planning. Help yourself as best you can, because we want to try to be efficient and not keep them on the table for a prolonged period of time. And making sure you know the surgical approach. If you are going to need a bone graft, make sure that you have that planned. If you have a second surgery team, they can be getting the bone graft for you while you're doing some of the repair and things like that. Sometimes you have to order implants that are needed. So kind of all of this preparation. Proper anesthetic medications, and make sure you have a safe anesthetic induction. You can see in this horse, they induced him with the Kimsey leg saver splint on to keep it as stable as possible. When you hoist them to put them on a surgery table, I never put hobbles on the fractured leg. I have a lead rope around it and just try to support it, but I don't want the hobbles hoisting it up and putting extra pressure on it. Making sure they're positioned on the table appropriately, which seems like something very simple, but you need to make sure that you yourself can access the fracture and the surgical approach that you need, but also that your imaging equipment can get there. So sometimes they have to be a little bit farther off the table than you would think, so that you can put the plate underneath if you're taking x-rays, or if you have a fluoroscopy unit, so that you'll be able to see what you need to do. And then obviously proper prep and everything else. One of the things that you'll need to do, as I said, you need to have your imaging equipment. One of the things I talked about is to reduce the fracture. You may have to use chains or something. So in this image, this limb is attached to the hoist, because even 12, 15 hours later, the muscles contract a lot, and you may not be strong enough to counteract the forces of the muscles of the upper limb. So hoisting the leg up, having the hoist support it, and using essentially the horse's weight to slowly reduce the fracture can be really helpful. So for implant application, I'm going to kind of go over the steps of some basic fracture repair. So step one, after you make the incision, is just to reduce the fracture. This is a radial fracture in a 2.5-month-old cria. So getting the fracture together as best you can. These are called bone reduction forceps. So bringing the fracture together. If you need to, doing a lag screw technique, which I have a slide on that in a minute, to keep the fracture reduced. So once I got it reduced as possible, I put screws across to keep the bone as anatomically aligned as possible prior to putting plates on. And so then you have to pick the appropriate plate size and length. The plate always goes on the tension surface of the bone. And if it's a big bone, you may have to put 2 plates on. So here's putting the plate on the bone. Because this was a diaphyseal fracture, and honestly, in any long bone, the plate needs to span the length of the long bone without interfering with the joint. This was the best plate I could get. The next one we had was too long. Again, spanning the entire length of the long bone. You want to bend the plate to contour it to the bone. So you want to make the bone and plate basically one if you can. So see how the plate is touching the bone all the way around. The dorsal surface of the radius is curved, so there's a slight curve to the plate. And then place the screws. Ideally, every hole has a screw in it. For large animal, that's not the case in people and small animal because they're much smaller animals in general. But for ponies, adult horses, even foals, you want to put a screw in every hole of the plate if you can, because that is the strongest construction that you can have. But sometimes the fracture configuration makes that impossible because you can't place a screw through the fracture line. So for this case, I was not able to place screws in the center of the plate because that's where all of the spiraling and comminution was. So I was a little bit limited in that. This just goes over how to do the lag screw technique, and the point of that is to compress the fracture lines together so that the fracture can heal. And this is another image of how you would do the lag screw technique to reduce a fracture and keep it stable. So I just put those in there for you to have to look at. Some things you may need to do to increase the strength of the construct is what they call plate luting, which is putting like bone putty with the plate. Sometimes some people will put antimicrobial beads that will put local antibiotics in the area, and then the beads slowly degrade over time, or a bone graft. And then flush everything, close the incision. Regional limb perfusion is something we can do, where we put a local high concentration of antibiotic in the area of interest just to, again, help decrease the risk of infection. Some fractures need casts, some don't. Some you can't put a cast on because of where the fracture is. You might do a standard cast, which is what's being placed in this image, or a transfixation pin cast, which I believe we talked about last week, where we're putting pins across and then incorporating them into the cast. And the point of that is to distribute some of the weight into the pins and the cast material and keep it off of the fracture just to help with repair. This is just a chart showing where the tension surface of the long bones are. And that again is where you're going to put the plate, is on the tension surface. So as I said, with recovery, most places just have a padded recovery stall with head and tail ropes that you can place on the horse. The fracture leg should always be up. If it's the down leg, then they have to move it underneath them, roll over it, and then push off on that leg to stand. If it's the up leg, then they're using their good leg to push up and stand off of when they recover from anesthesia. This is a sling recovery, so this can also be done. Some horses freak out with the sling if they're not used to it ahead of time. If you're going to do a sling recovery and have time, it's good to get the horse used to it pre-op so they're not as startled when they go to stand up. And then, as I mentioned, there are some pool recovery systems. Most places don't have them, but they are kind of cool if you do have them. So this is one type of pool recovery system. And if you're going to recover them in a pool, obviously you need to have some type of waterproof something over the surgical site so it doesn't get infected or exposed to water. So this horse is still anesthetized, and in the sling, it's placed into the pool. They have a raft to support its head, and it's still in the sling in the pool. This does sometimes put increased pressure on their chest cavity, but in general, the horses do well as long as their head stays above water. And then as the horse wakes up, the floor actually raises up. So they're using the hoist and sling to lift the horse up as the floor comes up with them. So they always have something under their feet, and then they can walk off of that once they are a little bit more stable, but they have that sling to help support them as they come out of the pool. This is another pool recovery system that they have at the University of Pennsylvania. So the horse is in the sling and it's placed in this pool raft, and there's the sling still on it. And then they'll pull them out of the raft, and you can see here their legs are just placed into, or the raft has these essentially extensions on it that the legs are placed into that prevents them from getting wet. And the theory behind the pool recovery system is if the horse starts panicking and thrashing and throwing their legs around, they can't hit a wall or anything because they're in a pool. So it's a softer area for them to kind of come out of the anesthesia. And then for the University of Pennsylvania system, the horses are lightly re-anesthetized. They can be taken out of the raft and then hoisted into a recovery stall where they can then stand. So really fancy equipment. I have never worked anywhere that had any of these fancy recovery stalls. So I've just had padded recovery stalls and head and tail ropes, and then thinking good thoughts for the horse that they stand up nicely. Post-operative consideration are antibiotics. So what type do you need to use based, and then how long is going to be based on level of contamination, type of fracture, things like that. If it's an open fracture, they're going to be on antibiotics longer. Analgesics, so they're going to be on pain medication. Usually we have them on bute. Some horses might need an epidural, which would be more for hind leg than forelimb fractures. I've never had a fracture patient need an epidural, but it is something that some need. And then we want to avoid just doing like local nerve blocks because it can increase the weight bearing before the fracture is healed. And so you have to kind of balance some of that out because, again, they're putting a lot of weight on a fracture that in many other species they would not be walking on yet. You want to keep the patient calm. I've had some patients that are pacing in the stall and things like that. So they might need some light sedatives. Ace-promazine that I mentioned way earlier in the lecture is a good one just to help decrease anxiety and things like that. We don't want to make them ataxic, but if they need a little bit to keep them calm, then you do what you need to do. And then external coaptation that some only need it for recovery, some need it for 3 weeks and then they're done, some need it for a long time. This is Mariska again, that little foal I was telling you about that I had. She was in the hospital for 10 months. She had her cast changed every 10 to 14 days. She was 2 months when she came in, and in foals, we have to change them sooner because they're growing. So we have to account for that. She was anesthetized, I don't know how many times to change her cast. And then if they're in a cast, you slowly wean them out of their cast. So she was weaned from her cast to bandage with a splint to just a bandage. This was on New Year's Eve, so she got sparkly bandage material. I said she was in the hospital for a very long time, so she became, a lot of people got attached to her. So the next thing is what went wrong. So you can have the most beautiful fracture repair and things can still go wrong. So some are technical failures. So if you have poor preoperative planning where you don't get good fracture reduction, you didn't bend the plate to contour to the bone as well as you would like, you didn't find all the fracture lines. So then the screws or plates create those stress risers I was talking about earlier, which then can cause the fracture to propagate. inappropriate imaging control. So radiology wasn't working or you weren't getting good angles. You may not have gotten the screw in all the way. There may have been, the screw might be too long or too short, things like that. Improper use of equipment, failure to completely tap the holes. And when we tap the holes, it makes a space for the threads of the screw to just seat into the bone and really lock in. And so if that's not done correctly, if you don't put the implants on like they should be, as I said in that when I was going over how to just place the plate, you want to make sure it spans the entire length of the bone. So if it doesn't do that, you can cause increase in or cause new fracture lines to appear. So there's a lot of different things that could happen. So this is, again, that radial fracture. Like I said, I wasn't able to place screws here because of the fracture configuration. We also had problems with radiology where it actually just kept breaking. And so I didn't have all the imaging I would have liked. And so this is 2 days post-op, and then 6 days post-op, you can see the plate starting to come off. And then there's a change in the fracture line as well. This is also that 6 days post-op where the proximal portion of the bone is not where it should be, and there were more fracture lines. Since this was a CREA, I could have gone in and fixed it with the new fracture lines that appeared, but the owners opted to just amputate her limb. So that's what happened next with her. There can be implant failure. So again, it might not be anything you did, but we're dealing with implants that are for people, not for horses. And so the implants need to be strong enough to resist loads during anesthesia recovery and post-operative weight bearing. And we do what we can. This pony, this is the radial fracture that we fixed last year. It was on her right radius. So she's in a bandage and a splint and also a sling to help keep her as stable as possible. And you'll see her x-ray shortly. And this is a way to reduce some of the pressure on the screws and plates. This is that olecranon fracture from earlier. So this was the repair in surgery, and then this is his repair after he stood up from recovery. And so the big thing to notice is right here, 4 of the 5 screws below the fracture line are bent. So this one is bent right at the plate interface. This one's bent just a little, but they're all straight here, and now they're bent. He didn't have a bad recovery, but it took him about 4 tries to stand up, and so he put a lot of pressure on the implants. But because they just bent and didn't break, he was okay. We managed him with a bandage and a splint, and he stayed in the hospital a little bit longer, but he went home, and he, after about 6 months, was put back into work and is back riding and jumping and all of that. So he was able to go back and have a job, which was really nice. Infection. So again, this is more common with open fractures, and this is actually Mariska's leg. So you can see the ooziness that's coming out, and then her second or third cast change. The sutures are dehiscing, and that's actually the plate, one of the plates, and you can see it there too. So that's one of the reasons why she was in the hospital for so long, is because she had the skin infection, and then eventually the implants got infected, and it was a nightmare. And the infection, again, can come from the soft tissue or the bone. There's a lot of damage, and it has a decreased blood supply. It can be harder to heal. And the implants are a foreign body, so that's just a nidus for infection anyway. And other things that can happen are delayed union. And what that means is there has been adequate time for healing, but the healing is not complete. In general, long bone fractures should heal within 4 months in adults and about 3 months in foals, because foals are growing, so they just have more healing factors and growth factors in their body anyway that just helps them heal a little bit faster. Non-union is the healing repair process has stopped, but bony continuity is not restored, so the fracture hasn't actually healed and it's not healing anymore. Their body's not trying to heal it anymore. And there's different types, but we'll just go over kind of what can happen with this. So why does this occur? It could be that the implants are infected, the bone was infected, you may not have gotten the bones reduced appropriately. if there's the internal fixation isn't adequate, or there's the bones are still mobile, so it didn't actually fully reduce and fixate the bones together. Soft tissue disruption. So I won't read all of them. There's a lot of things here. And then just instability, which also doesn't allow proper bone healing because there's micromotion between the fragments, and that will prevent the bone from actually being able to heal. And with instability, the implants usually loosen over time and things like that. So this is the radial fracture that we repaired. And so kind of you see her radiographs. So this is when she came in. And so these are bone fragments. So she did, even though it looks like a simple transverse fracture, she did have comminution. If I'm remembering correctly, she did not have a caudal lateral cortex. That was what all these pieces were from. So we were limited in some aspects of where we could put plates and screws. Because it was in the radius, we double plated it. So there's 2 plates on that you can see. And we also put a bone graft in because there's still space between the proximal and distal portions of the bone, because again, all of these fragments were part of what came apart. This is 4 days post-op, and then we monitor. She was in the hospital for probably 2 months. Looks like it's starting to heal. The fracture lines are getting better. One thing to remember too, when you're dealing with fractures, the fracture line is always going to get bigger before it gets smaller, because the osteoclasts go in, take out all of the affected damaged bone first, so it makes the space bigger, and then the osteoblasts come in and lay down new bone. So it's not a surprise that it gets a little bit bigger before it gets smaller, because that's just the healing process. This was right before she went home, and this is something we knew was going to take a long time to heal because parts of the bone were missing. It was a pretty big fracture. And again, as I said earlier, in most adult horses, we don't even attempt to fix radial fractures because they have such a poor prognosis, because our implants just aren't strong enough. But Ruby is a pony, and so she weighed right at, I think, 350 kilograms, and the owner wanted to try, so we tried. So 2 months post-op, not looking too bad. But then when she came in 6 months post-op, there's extra bone proliferation proximally. And on the lateral view, there's space between the screws and the plate. So the screws are starting to back out. There's no bone here anymore, and there's just extra bone proliferation. And then at 8 months post-op, you can see a lot of the screws have backed out, and there's a lot of bone proliferation on the proximal surface. And the reason for this is just complete instability of this fracture. The owners did not want to give up. And there are a couple people in the United States, not very many, who do limb amputation and prosthetics. And so her owners took her to another veterinarian to amputate her limb and then fit her for a prosthesis. I don't know how that has gone. And we can debate the ethics of that at another time. But you can see this is non-union. It's not even delayed because the bone healing process is completely stopped. There's no more healing that's trying to occur at this fracture site. And all this extra bone proliferation proximally is just because of the instability and the plates irritating the bone. So unfortunately, it did not turn out the way we had hoped. But at the same time, this isn't unexpected, because radial fractures are very hard to repair in horses because the plates and implants just are not that strong. So lastly, when to remove the implants. Indication. So when the function of the implant is complete, so the fracture is healed, or if we're using them for angular limb deformities, that deformity is healed. If the presence of the implant is going to cause lameness, so plates and athletic horses, except for olecranon fractures, those will stay in. But if it's a condylar fracture repair or something like that, once the fracture is healed, you're going to take the plate out because it can make them sore and uncomfortable. Some people want the implants removed if it's not cosmetic. That's going to be more an owner thing. Or if the presence of implants prevents resolution of sepsis or infection. If it's infected, you want to take them out stepwise. And if you can, you try to leave them in and manage the infection until the fracture is healed. So that's what we did with Mariska. You could see that from those images earlier where you could see the plate. We managed her on long-term antibiotics to try to get her through until the fracture was stable enough and had a good enough fibrous union that we could then remove the implants, which took about three to 4 months. She was on antibiotics for a long time just to try to get that resolution. So you have to remove if there is an infection around the implant. But again, if you need the implant for the stability, you balance the infection with trying to keep the implant in long enough for the fracture to heal. So signs of infection are going to be lysis around the implant. So you can see the decreased opacity around the screw. So that screw is infected. Or if the screw or plate is creating growth disturbance. So again, that's more with angular limb deformities and foals. If the screw breaks or it loosens, or the plate, or if you're using pins, if any of those start to loosen, they need to come out. And so again, any signs of infection or disruption to basic movement. Risk of implant removal, infection of the soft tissue. So you want to close all of the dead space. Sometimes you need to put them back on antibiotics after you remove the implants, especially if they're infected. There's a potential that they could refracture the limb after the plate removal. So when things are double plated, you can do what we call a stage removal, where you remove one plate and let them have 30 days of rest before removing the other. And that just helps the bone start to remodel and get stronger before taking the second stabilization plate away. And then you can also potentially break the screw or not be able to get it out, which that's a whole other thing of trying to deal with that, which we will not go into in this lecture. So the overall take-home message is forces acting on the bone determines the fracture configuration. There's the intrinsic or internal forces and the extrinsic external forces. You want to make sure you have good proper surgical planning, good imaging, you have the correct equipment and you know how to use it. Post-op planning and maintenance and how to deal with complications. You have to understand that some fractures can't be fixed. Again, those upper limb fractures in adults. Foals have a better prognosis than adults in general because they're lower weight and lay down more frequently. The biggest thing is manage owner expectations with that olecranon fracture repair, that bent the screws and recovery. When I talked to the owner after, because I warned her about all of these things, she was upset, but not at me. She's like, I'm disappointed, but you told me this could happen, so we're fine with it. And so keep moving forward. So making sure you just manage what the owners, what they expect and what can be done if certain complications arise, and that you can do everything right and still have a less than ideal outcome. So these are the references. And then are there any questions? I realize that was a lot of information. I was trying to give you as much information as possible. So question in the chat is what with the antibiotics that I would recommend to use for regional limb perfusion. So the most common one that we use in the United States is amikacin. For most adult horses, it would be, it's cost prohibitive to give it systemically IV because it's way too expensive, but that's the one we tend to use most often for regional limb perfusions. Whether it's for a laceration that's near a joint or for fractures, we tend to use amikacin. Any other questions? All right, I don't see any more questions, but I know that we have until 10:50. We definitely won't get through all of the next lecture in that time frame. Do you want me to go through some of it? There's a second question. Is amputation common in horses with chronic severe infections? Amputation is not a common thing we do in horses. There are a couple people who will do them. Personally, for me, I'm ethically against doing amputation in horses. They're supposed to have 4 limbs. There's a lot of things to take into consideration, like the size of the horse, their temperament, things like that. There's not a ton of research out there about it. The most recent paper that I read, which may not be the most recent paper that's been published at this point, was looking at amputation, and the paper said that they had like an average of 2-year survival rate. However, if you look at I think it was somewhere between 8 and 14 horses. I can't remember exactly how many were in the paper, but most of the horses lived an extra like 6 to 12 months. One horse lived 6 years, which is what skewed the average survival to make it 2 years instead of a lot less. If that one horse wasn't in there, it would have been about a 6-month survival. And so a lot of them were done on brood mares to try to be able to keep breeding them. And it was from the fetlock down. So in Ruby's case, when I'm still not even sure how he's going to fit a prosthetic to her leg because her fracture is so high. Even if he's able to kind of amputate just at the proximal end of the radius, it's going to be really hard to fit a prosthetic. I'm assuming they'll have to have something go up over her withers. My resident that was on the case, she still keeps in touch with the owner. So I'm not sure, but that resident has since finished and I haven't chatted with her about Ruby. So I'm not exactly sure how they're doing the prosthetic on her. But again, amputation is not common in horses versus like we talked about last week where goats and sheep and things, it's a little bit more common in them, kind of like with small animal, but in our large animal, like large species, we usually don't do amputation. So, any other questions? All right. Again, with time-wise, a question from last week. Okay. Is a pot belly, I'm sorry, you're asking like the pot-bellied pig urolithiasis compared to the pot belly. Oh, if they have a pot belly, if the goats have a pot belly, is that related to urolithiasis? I'm assuming, is that what you mean? Like if they have a distended abdomen type of thing, is that what you mean by pot belly? If that's what you mean, then yes, goats can have like a distended abdomen or kind of a pot belly appearance. If their bladder's ruptured, they don't usually have that if their bladder hasn't ruptured because they don't have a uroabdomen. So if it's just, if you can just see the distended bladder on ultrasound and things like that, they're not necessarily going to have a distended kind of pot belly appearance. But if their bladder has ruptured and they have a uroabdomen, they could have that. Sure thing. Any other questions?
No more question, Jordan.
Okay.
For now.
Yeah.
เพราะฉะนั้นเนี่ยเวลาที่พวกเราแชร์เช่นวัฒนธรรมเรื่อง
With the time, do you want me to do part of the next lecture or just let the students read over it? And if they have any questions, we can address it next week. I know it's getting kind of close to when they have to go to their next class.
Yes, they have class at 10:30, but the lecturer allow us to have time until 10:50 if you have,
Okay.
if you want. Yep.
Okay. Yeah, I can start the next one. We won't get through all of it.
ตอนนี้หนูเห็นไหมประเทศไทยรู้ไหมว่าเขา
Yep.
ทำพยาบาลในกลุ่มที่อยู่ในวอร์ดติดเชื้อโควิดเขาทำยังไงรู้ไหมคะ
Wait, can you see the slides?
Yes. Yes.
Okay, it worked this time. Great. Okay. So we'll see what we can get through with equine urogenital. Hopefully you already got the notes, and then like I said, we won't get through all of it, but we can go over any questions and things next week too, or feel free to email me as well. So start off talking about foals. So one of the things that they can get is a ruptured bladder or a uroperitoneum. Or uroabdomen. It's more common in colts. They have a longer, narrower urethra, and the bladder rupture usually occurs during parturition. There's a prevalence of 0.5 to 2.5%. And they usually appear healthy and nurse within the first 24 to 48 hours, and then they start getting sick and deteriorating. The tears normally are about 2 to 5 centimeters long and usually occur on the dorsal surface of the bladder. So you can see that's an example of a bladder tear right there. Clinical signs, they're normally okay at first, and then they'll have decreased nursing behavior, might seem a little lethargic, and then their abdomen progressively gets distended because urine's leaking into their abdomen. And then a lot of times they'll have signs of colic as well, which again, that's for next week. And we'll talk about full signs of colic versus adult horse signs of colic. They may posture to urinate, so drop their penis. They may be able to pass small amounts of urine. They may constantly try to posture to urinate. And one thing this posture can be confused with is a meconium impaction, which we'll talk about next week as well. But usually with the meconium impaction, the foals will have their tails up and they'll wiggle them a lot, which they don't usually do that with a ruptured bladder. They're just posturing to urinate and can't, versus having that stance and also moving their tail back and forth quickly. Diagnostics are going to be one abdominal ultrasound to see what's going on. And these two ultrasounds are from two different foals. This one, there's a huge uroperitoneum, and you can see the bladder's really small, versus on this one, there's some little fluid pockets, but they can still see the bladder, that small intestine, that's the umbilical artery. So ultrasound, depending on where they are and how much urine may have been deposited into their abdomen, may not be like this one. You would need to do a little bit more to know for sure what's going on. Whereas if you see this, you're like, okay, yeah, they definitely have a ruptured bladder. Blood work's really important. They'll will tend to have a hyponatremia, hypochloremia, moderate to marked hyperkalemia, and then azotemia. And then if these electrolyte abnormalities are really bad, especially the hyperkalemia, they can get muscle tremors and neurologic defects. So they can come in pretty sick. Abdominocentesis is another thing where you just you put a teat cannula into their abdomen and get a sample of fluid. If the abdominal creatinine is greater than 2 times the peripheral creatinine, that's pretty definitive for a ruptured bladder. So again, like in this case, when you may not be sure what that fluid is, that is a good indicator. This one, it's fairly obvious, but in this ultrasound, you may not know, and that's where the abdominocentesis could come in handy. If they're really sick, they need to be stabilized before they're anesthetized. So the first thing is to correct the hyperkalemia. So again, those clinical signs can be muscle tremors. They may have some cardiac arrhythmias. So there's a couple different treatment options. One is to give calcium carbonate. So you dilute it into a 500 or 1,000 ml bag of saline and give it slowly over about 10 to 20 minutes. And what that does is it raises the resting membrane potential. So it basically antagonizes the effects of the potassium. And then after you do this, you want to continue to treat them with IV fluids, but fluids that are low in potassium. So here we have lactated ringers, which are lower in potassium than other fluid names that we have are Plasmolite or Normasol. I'm not sure what the fluid are what they're named where you're at, but at least for us, lactated ringers have a lower potassium content, or even saline wouldn't have any. Dextrose is another option. You give a 5 to 10% solution, and that causes the release of insulin, which will activate the sodium potassium ATPase pumps, and that will actually drive the potassium back into the cell. So it drives the extracellular potassium back into it so that it's intracellular, which will help lower the serum potassium levels. The goal is to have a potassium of less than 5.5 milliequivalents per liter prior to surgery. Another thing that can be done is to drain the abdomen, especially if there's a lot of excess fluid, because it will remove the excess potassium, but also if it's a severe uroabdomen, there's going to be increased pressure on the thoracic and abdominal organs, which can make ventilation difficult when they're under anesthesia. If the abdomen is going to be drained, then you insert a chest tube into the ventral abdomen and drain the fluid that way. But there is a risk of hemodynamic collapse when you do that. So you need to make sure you're also supporting them with intravenous fluid therapy to balance out their fluid volume so they don't crash. The procedure to fix it is cystoscopy. So this is going to be under general anesthesia and dorsal recumbency. If it's a male, which again, usually it is, you'll suture the prepuce closed. If the external umbilicus is present, which again in a young male foal they should be, you can oversew that as well, basically to keep anything that might be draining out of the umbilicus from the surgical site. The incision begins 2 to 5 centimeters cranial to the umbilicus and it extends caudally. If the umbilicus is present, then you're actually going to do a fusiform incision. So the umbilicus is here in this image. You'll actually kind of come around like this because you're going to remove the umbilicus and the remnants as you do this surgery. The midline approach in males is as you extend caudally, because of the penis and prepuce, you have to make your midline incision becomes paramedian. And you can then retract the penis and prepuce laterally, as you see here, and then still incise on the linea alba that way. And that way you're still going through the linea as you enter the abdomen. Once you open the abdomen, with the bladder rupture, especially if you haven't drained it, you're going to want to have suction ready so you can suction the urine out of the abdomen. If the umbilical vein is still present, you're going to locate that and transect it. I have this image up here just to remind you of the anatomy of the umbilicus, the umbilical vein, which goes cranially towards the liver. The urachus goes to the bladder, and the umbilical arteries are on either side of the bladder. If the umbilical vein is present, then you will double ligate it and transect it. And then expose the bladder. You want to maintain traction on the bladder and or the urachal remnant if it's present, and retract it caudally. Place stay sutures once you get it out of the abdomen so that you have a grip on it. I use cruciate patterns for this. I feel like that helps distribute the pressure and the tension around the suture line better than just doing a simple interrupted. And then find where it's ruptured. This image is ruptured in the bladder, but sometimes the rupture can actually be in the urachus. So look there too if you're not finding an obvious one in the bladder. There's a couple ways to manage the tear depending on the size. Because the edges are now damaged from the tear, you're going to excise those edges and then suture it together in a double layer as shown in this image. If it's at the apex of the bladder, you can actually resect the apex of the bladder, which we'll talk about on the next slide. So again, if you're going to close the tear, after you remove the damaged edges, you just close in 2 layers, usually a double inverting. I tend to use a Cushing's pattern and use either 2-aught or 3-aught, some type of monofilament synthetic absorbable suture. Here we have monocryl or PDS, and I tend to use PDS. It does last a little bit longer, but the monocryl can be degraded by the urine, and it might, if some of the suture gets within the bladder and is exposed to urine, it could degrade before the tear is fully healed, which usually takes about 7 to 10 days. The bladder heals really fast, but if the sutures start to degrade prior to that, it could damage the repair. If you're going to resect the apex of the bladder and also have to resect the umbilicus, again, the umbilical vein is cranial, which you would have already resected at this point, and then the umbilical arteries and urachus are caudal and next to the bladder. You'll isolate the both umbilical arteries and remove the fascia that's connecting them to the bladder, and then double ligate and transect those arteries. To resect the urachus and the apex of the bladder, you would put Doyen forceps across the apex of the bladder and then transect the bladder and the urachus away. You'll have stase sutures already in the bladder because you've already put those in there. And then the opening that you've created into the urinary bladder, you'll close in 2 layers as you did with the tear. So again, 2 Cushings is usually what I do, a double inverting closure with the same size suture. Once the bladder is closed, you want to check it for leakage. So you can infuse it with saline and see if anything leaks out of the sutures. And then if everything's good, place the bladder back in the abdomen, lavage it really well. You don't want to leave the urine in the bladder in the abdomen, as that could affect some of the intestinal structures. And then you'll close in 3 layers, the linea, then the subcu, and then the skin. Prognosis for this is good with surgical correction. Potential complications are septicemia. Since you have most likely remove the umbilicus in most of these foals, you can culture it and see if anything grows and then treat appropriately. They can get a septic peritonitis. There's pretty low risk, and if you do a good lavage of the abdomen, that can help reduce that even more. And then there's the potential that they get intestinal adhesion formation that also has a low risk, but it is something that could happen and then cause colic issues later on. Another condition that foals can get, it's related to the question, why are they more common in colts? Because colts have a long, narrow urethra, there's pressure when the mare gives birth. As the foal's coming out of the birthing canal, there's more pressure on the foal's abdomen. And since their urethra is so long and narrow, there can be so much pressure that the urine can't get out of the bladder if it's full because it has such a long passageway to go, and then the bladder just ruptures. Versus in females, they have a very, very short urethra, so if there's extra pressure on the bladder as they're being born, it can just come right out of the urethra because it's probably this long versus the male is going to be probably even longer than that. So it's just the urine doesn't have an easy way to escape in the colts like it does in the female, so that's why it's more common in them. Okay, next condition is a patent urachus or infected umbilicus. It can infect the external or internal umbilical structures, and this can occur in foals. Next question, drugs, antibiotics of choice for urogenital surgery. Some of it depends on what the infection is, but in general, we tend to use broad spectrum antibiotics. So either procaine penicillin and gentamicin or potassium penicillin and gentamicin. If they have a UTI, trimethoprim sulfa is excreted through the kidneys and actually can treat bladder infections really well. So if you're worried about that, that's another really good antibiotic. But those are probably the most common ones that we'll use for urogenital type surgeries, just a basic broad spectrum. But like I said, for urinary tract infections, trimethoprim sulfa, which we call TMS for short, works really well for those.
Dr. Jordan, excuse me. I think it's about the time for the next class for students. So I think it would be better if we can continue this section for next week. Okay.
Okay. Yep.
We can do that. There is a question from the chat.
Is there another one I saw? Talked about why it's more common in colts, antibiotics. I don't see any more.
Oh, yeah. It's that, yep. New message.
Oh, and
yes. There is another question.
Do we have another technique to exteriorize the penis that isn't the internal pudendal nerve block? So this is kind of going back to last week. For cattle, you can sedate them and see what will happen. Like we can sedate them with xylazine. You just have to be careful with that because ruminants are much more sensitive to xylazine than horses. If we're talking about horses and trying to exteriorize their penis, you can actually, they tend to exteriorize it with just sedation. So giving them xylazine or acepromazine, that kind of anti-anxiety medication I was talking about earlier, that can also, it's actually a potential, in this lecture a little bit later, potential complication of giving acepromazine is that the penis stays out and the stallions can't retract back up. So for horses, usually sedation, and then if I need to, I'll give them xylazine. So I don't do pudendal nerve blocks for horses nearly as much as I had to do in cattle, because cattle, it's a lot harder to exteriorize their penis and you have to be real careful with the sedation. So usually pudendal nerve block for cattle, but for horses, sedation and acepromazine. So.
That's great. Thank you very much, Dr. Jordan.
You're welcome.
We can continue this session for next week.
Okay.
Any more questions? If not, okay, we will let students to study for the next class. So thank you very much, Dr. Jordan. Thank you very much for your lecture. Wonderful lecture. Have a good night. Thank you. See you next week. Yep.
Bye.
Yep. Bye.